You're listening to Who Said, a cardiology board review series. No fluff, just facts.
This episode is about transposition of the great arteries. We'll go over the physiology, imaging features, repair, post-repair issues, and then delve upon CC-TGA. Let's start with the physiology. TGA, or transposition of the great arteries, is defined as any condition where the aorta arises from the right ventricle and the pulmonary artery arises from the left ventricle, regardless of the location of the ventricles or the position of the heart. Complete TGA, or D-TGA, is defined by having atrioventricular concordance and ventricular arterial discordance, such as the blood flow is from right atrium to right ventricle to the aorta, and from the left atrium to the left ventricle to the pulmonary artery. The specifiers possible are complete TGA with intact interventricular septum, complete TGA with ventricular septal defect, complete TGA with ventricular septal defect and pulmonic stenosis. VSD is present 45% of the time, in which case the hypoxemia is less severe because then there can be mixing across these parallel circuits. LV outflow tract obstruction is present 25% of the time. Coarctation of the aorta is present 5% of the time. In D-TGA, since the blood is being cycled in two parallel circuits, survival requires the presence or creation of some intracardiac shunt, such as an ASD or VSD, or extracardiac shunt, such as PDA. As the ductus arteriosus and foramen ovale close soon after birth, the neonate quickly develops severe hypoxemia and metabolic acidosis because the oxygenated and unoxygenated blood no longer get a chance to mix. The neonate will die within a week unless they are given an emergency balloon atrial septostomy to allow for oxygenated blood in the left atrium to flow into the right atrium, to be sent into the systemic circulation, and a PGE1 if infusion to keep the ductus arteriosus open. L-TGA occurs at 1/10 the incidence of D-TGA. In congenitally corrected TGA, which is L-TGA or CC-TGA, two wrongs make a right, so they say. Blood flows from the right atrium through the mitral valve to the left ventricle to the pulmonary artery to the pulmonary vein to the left atrium through the tricuspid valve to the right ventricle to the aorta. The D and L prefixes refer to the position of the aorta in relation to the pulmonary artery. In D-TGA, the aorta is on the right side, D for dextro, leading to the abnormal circulation where deoxygenated blood is sent to the body. In L-TGA, the aorta is on the left side, L for levo, but the ventricles are inverted, resulting in congenital correction of the abnormal anatomy despite the inversion of the ventricles. Now let's talk about imaging. How can you figure out which one is the RV? The RV will have coarse trabeculation, a septoparietal muscle bundle, chordal insertions of the tricuspid valve into the RV, and discontinuity between the tricuspid valve and the pulmonary valve. The LV will have less trabeculation, smoother septal surface, an inlet guarded by the mitral valve, papillary muscles, and continuity between the mitral valve and the aortic valve. Echo of CC-TGA, which is L-TGA, will show extensive trabeculation of the left ventricularized right ventricle, causing it to sometimes be mistaken for non-compaction cardiomyopathy. Now let's talk about repair. In D-TGA, which is the one that occurs most of the time, 10 times the prevalence of L-TGA, in D-TGA you need surgery early in life. There are several repair strategies which are mutually exclusive. Atrial switch, Mustard and Senning, Rastelli procedure, and arterial switch. Atrial switch, Mustard and Senning. Basically, SVC and IVC blood is routed to the left ventricle, which acts as a right ventricle and pumps into the pulmonary arteries, while the pulmonary venous blood is routed into the right ventricle, which acts as a systemic ventricle and pumps into the aorta. The Rastelli procedure, which is done if VSD is present as well as LVOT obstruction. You close the VSD while constructing a conduit to direct the LV volume to the aorta and the RV volume to the pulmonary arteries. They no longer routinely do the arterial switch procedure, which is the switch of the aorta and the pulmonary trunk. Now, let's go over each of these in detail, starting with the atrial switch procedure, which are the Mustard and Senning procedures. The Mustard, 1959, and Senning, 1964 operations have long been phased out since the 1980s, but we still encounter some older adults more than 50 years of age who have had this done. In atrial switch, the systemic veins, SVC and IVC, are, quote, baffled through the atrial septum to the mitral valve and the left ventricle. Like sideways trousers, each leg of the pants attaches to either the SVC or the IVC, transporting deoxygenated blood through the lumen of the trousers to the waist of the trousers, which empties through the mitral valve into the left ventricle and out the pulmonary artery. Meanwhile, the newly oxygenated blood through the pulmonary veins are able to reach the tricuspid valve to enter the right ventricle because the opened atrial septum allows flow from the posterior left atrium through the space between the pant legs of the baffle to reach the right atrium. In this atrial switch procedure, the right ventricle remains the systemic ventricle, unlike in the arterial switch or Rastelli procedure. The difference between the two variations is that in a Mustard operation, after removal of the atrial septal tissue, an interatrial channel is made using a pericardial baffle, whereas in Senning operation, an interatrial channel is made by folding tissue from the RA wall and the atrial septal wall. Now let's move on to talk about the arterial switch procedure, which is the Jatene procedure. Since the late 90s, they have been doing the arterial switch procedure for D-TGA. First, a patch of pericardium is harvested to use for patch augmentation of the neopulmonary artery and or VSD closure. The aorta is transected above the sinotubular junction, and the coronary arteries are disconnected with a button of aortic. The main pulmonary artery is transected. The coronary arteries and their buttons are anastomosed onto the base of the main pulmonary artery, which will function as a neo-aorta, which is then anastomosed to the true ascending aorta. The old aortic root is then anastomosed to the main pulmonary artery with patch augmentation as needed. At this point, the LV ejects through what used to be the old main pulmonary artery route into the true aorta, and the RV ejects through what used to be the old aortic route into the true pulmonary artery. Now, what if you have TGA with ventricular septal defect and left ventricular outflow tract obstruction? In 10% of TGA cases, patients have TGA with a VSD and an LVOT obstruction. The obstruction in the LVOT can be from pulmonary valvular stenosis, posterior deviation of the conal septum, a discrete membrane or diffuse fibromuscular tunnel of the LV outflow tract, straddling tricuspid valve apparatus protruding into the LV outflow tract through the VSD, or complex obstruction from anomalous attachments of the mitral valve. Cyanosis and hypoxemia is more severe when LV outflow tract obstruction is present compared to when LV outflow tract obstruction is not present in patients with TGA and ventricular septal defect. How about the Rastelli operation? TGA with VSD and LV outflow tract obstruction is repaired with the Rastelli operation. This involves enlarging the ventricular septal defect and placing an angled ventricular septal defect patch to direct blood from the left ventricle diagonally across the VSD to the anterior aorta. A conduit is placed from the right ventricle to the pulmonary artery. Because placement of the RV to PA conduit reduces the functional size of the RV, the procedure is relatively contraindicated if you have hypoplastic right ventricle. This procedure has the benefit of restoring the left ventricle as the systemic ventricle. However, the RV to PA conduit often requires multiple reoperations for replacements. Now let's talk about post-repair issues. Complications of the atrial switch procedure, which are the Mustard and Senning procedures. Complications of the atrial switch procedure include baffle stenosis and baffle leaks. The SVC limb is the most common site of baffle stenosis. Most patients are asymptomatic, but sometimes it can manifest as SVC syndrome. The presence of a pacemaker or ICD lead increases the risk of baffle stenosis. Baffle leaks often have bidirectional shunting, so there may be hypoxemia or erythrocytosis. Bubble study will be positive. Fortunately, most baffle leaks can be fixed. Other complications are arrhythmias, sinus node dysfunction, atrial flutter, and SVT in more than 50% of patients due to all the suture lines that are made in the atria. Systemic RV failure because the RV is not designed to serve as a systemic ventricle. tricuspid regurgitation from functional annular dilatation, and the need for the RV to pump against high systemic resistance. How about complications from the arterial switch procedure, which is the Jatene procedure? Because the pulmonary arteries are draped over the aorta to bring them anteriorly, the aorta may compress the branch pulmonary arteries and cause branch pulmonary artery stenosis. Because the neo-aortic root started out as a pulmonic root, after it starts being used as an aortic root and encounters systemic pressure, you may see slow progressive neo-aortic dilation and pulmonic regurgitation, eventually requiring pulmonic valve replacement. Pulmonic stenosis affects 5 to 15% of patients after the arterial switch and may occur anywhere in the pulmonary tree, including the pulmonary valve, main pulmonary artery, and branch pulmonary arteries. You may suspect this after hearing a systolic murmur. Echo has low sensitivity to detect this, so MRA and CTA are used for evaluation. Since the coronary arteries were manipulated, there may be coronary artery occlusions. You should have a low threshold of doing a coronary CTA or invasive coronary angiography in these post-arterial switch patients if they complain of chest pain or LV dysfunction. Coronary occlusions may be asymptomatic but may also manifest as sudden cardiac death. How about complications of the Rastelli procedure? Late subaortic stenosis can develop if the interventricular tunnel to the aorta is not adequately large, especially if the patient grows. Many patients will develop conduit obstruction and conduit failure as noted above. To summarize what we went over, potential long-term complications in D-TGA repairs are, after the atrial switch procedure, which are Mustard and Senning procedures, systemic RV dysfunction and tricuspid valve regurgitation, tricuspid valve meaning the systemic AV valve, due to RV facing high systemic pressures, baffle obstruction, especially of the SVC baffle, sinoatrial node dysfunction and atrial arrhythmias due to suturing into the atrial tissue, and LV outflow tract obstruction. Complications after the arterial switch procedure or Jatene procedure are dilatation of the neo-aortic root and regurgitation of the neo-aortic valve due to facing high systemic pressures, arterial stenosis at a level of anastomosis, ostial coronary artery stenosis, and branch pulmonary artery stenosis due to compression of the aorta on the pulmonary arteries. Complications after the Rastelli operation are RV to PA conduit dysfunction and need for frequent replacement, subaortic stenosis at a level of the LV aorta baffle, and ventricular dysfunction. What do the 2018 congenital heart disease guidelines say about managing post-repair issues in TGA? Guideline-directed medical therapy is reasonable to determine indications for aortic valve replacement in adults with D-TGA after arterial switch with severe aortic valve regurgitation. That's a Class 2A recommendation. Catheter or surgical intervention for pulmonic stenosis is reasonable in patients with D-TGA after arterial switch or who have symptoms of heart failure or decreased exercise capacity attributable to pulmonic stenosis, Class 2A. Now we'll talk about CCTGA, congenitally corrected TGA, also known as L-TGA. Congenitally corrected TGA will eventually have eventual systemic TR, since the tricuspid valve was never built to sustain systemic pressure, eventual systemic RV dysfunction, since the RV was never built to sustain systemic pressure, ventricular septal defect, pulmonic stenosis, dextrocardia or mesocardia, and complete heart block, which occurs at 2% per year. 80% of patients with congenitally corrected TGA have a dysplastic or Epstein-like malformation of the tricuspid valve. This anatomically abnormal systemic atrioventricular valve is at risk for progressive TR, which is an independent predictor of death in congenitally corrected TGA. Systemic RV dysfunction is often attributable to long-standing tricuspid regurgitation, and efforts should be made to relieve the tricuspid regurgitation before worsening dysfunction. Many adult congenitally corrected TGA patients are referred for tricuspid valve replacement late, when symptomatic and already suffering from moderate to severe TR and ventricular dysfunction. Tricuspid valve repair has been attempted. However, recurrent clinically significant TR is observed frequently after tricuspid valve repair in patients with CCTGA. Hence, valve replacement is preferred. What do the 2018 congenital heart guidelines say about intervening on tricuspid regurgitation in CCTGA? Tricuspid valve replacement is recommended for symptomatic adults with CCTGA and severe TR and preserved or mildly depressed systemic ventricular function. That's a class 1 recommendation. Tricuspid valve replacement is reasonable for asymptomatic adults with CCTGA and severe TR with dilation or mild dysfunction of the systemic ventricle, class 2A. So, basically, tricuspid valve replacement is recommended as class 1 for CCTGA if there are symptoms, severe TR, or preserved or mildly depressed systemic ventricular function. If there are no symptoms, then tricuspid valve replacement becomes class 2. Now we'll spend a little time touching on Truncus Arteriosus before finishing up. Persistent Truncus Arteriosus has a single multicuspid semilunar valve with a single vessel, the truncus, arising from the ventricles and giving rise to systemic, pulmonary, and coronary circulations. Thus, both persistent Truncus Arteriosus and tetralogy of Fallot with pulmonary atresia are characterized by a single vessel emanating from the heart. Diagnosis of tetralogy of Fallot with pulmonary atresia relies on the presence of a pulmonary valve remnant by clinical imaging. That criterion permits differentiation of tetralogy of Fallot with pulmonary atresia versus persistent Truncus Arteriosus. Usually tetralogy of Fallot does not have pulmonary atresia and instead have pulmonary stenosis, so it is easy to distinguish tetralogy of Fallot from Truncus Arteriosus. Surgical repair of Truncus Arteriosus should not be deferred for longer than a few months due to a high incidence of pulmonary vascular obstructive disease or Eisenmenger syndrome if it is not corrected early. Due to the absence of a main pulmonary artery, surgical repair of persistent Truncus Arteriosus involves closure of the VSD and placement of a right ventricle to pulmonary artery conduit. Truncus Arteriosus in an adult has almost invariably been repaired in childhood, and in the rare circumstances when an adult has unrepaired Truncus Arteriosus, Eisenmenger physiology is typical, so it'll be quite obvious. Pulmonary hypertension may be present in repaired patients with Truncus Arteriosus. Truncus Arteriosus will have slightly decreased oxygen saturation due to mixing at the great artery level. But patients with Truncus Arteriosus are not usually profoundly cyanotic. The 2018 Congenital Heart Guidelines do not have specific recommendations about the management of Truncus Arteriosus. That's everything for transposition of the great arteries and Truncus Arteriosus.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.